So I'm going to talk about HPV vaccination. And as I said, we're going back to the beginning. If you can prevent HPV from occurring in the first place, you can prevent all of those problems we've been talking about. And we're going to give you some updates of HPV vaccination where we are currently in the beginning of 2014. We know, and we've told you several times, that HPV cancers in women are a big burden. There aren't as many, there's about 530,000 in cases per year worldwide in women, but that includes cervix, vulva, vagina, anal cancers, oral cancers, and some oropharyngeal cancers. In men, there's 33,000 cases a year, and it's a bigger problem with anal cancer, some penile cancer, some oral cancers, and some oropharyngeal cancers. But it's big news, the association with oral cancers, particularly in North America and in Europe. And we've seen this picture many times. You can see the burden, you see the different colors whenever you do this, but the lightest colors here are in Saudi Arabia, the light here, light in Australia, and centralized around the equator and Central Africa, India, and Central America. So apparently every minute there's a woman diagnosed with cervical cancer, and every 2 minutes a woman dies with cervical cancer. You can see the different rates there. So, to prevent the HPV virus from getting into the cells, the HPV virus needs microscopic trauma and a tear in the epithelium, and it gets to the basement membrane. But it doesn't cause a systemic infection. And if I can get this to, I think there's an animation here, you then can have antibodies, and if the antibodies can bind onto this, you can stop that infection from happening. And the only way to generate those antibodies reliably is to immunize the patient. So natural infection does not go below the basement membrane. The only way you get problems with these cells below the basement membrane, with HPV below the basement membrane effects of, is with invasive cancer. So warts, pre-invasive disease in the head and neck, pre-invasive disease on the vulva and the anus, all is epithelial, and there is no real good systemic response to that immunologically. It is actually very difficult for us to measure that on natural infections. What is different about, before I move on, what is different about vaccination is that vaccination gives you an intramuscular injection, usually in the upper outer arm, and by that you are stimulating the systemic immune response, and you're generating antibodies which can then be present, and when the patient is exposed to HPV, they are present in the circulation and they can neutralize the HPV. So the difference between natural infection does not give you future protection, but immunization gives you future protection against infection. So we know that HPV causes it. The relative risk is higher than for lung cancer. The lifetime risk of infection is about 80%. More than 70% of HPV types are oncogenic. Most infections are transient, and clearance occurs in about 12 to 18 months. 10% of infections persist beyond 2 years, and you need persistent infection to get cancer or pre-cancer, and you need persistent infection with an oncogenic type, or type 6 or 11. And it usually takes 10 to 20 years for HPV infection to cause a cancer. So it doesn't do it very well. It causes a lot of cancer, but it doesn't do it really very well. We, however, do see patients that are young, and for some reason they get exposed and they get a cancer very early. I see patients who are less than 25. Mario sees them, you may see them here, but that is a rare entity to see that. And for most of the patients, they have had HPV when they were in their teens, and they get a cancer in their late 30s or 40s. That would be commonly what happens. We've talked about the different types. We talked about globally being 16 and 18 being responsible for 70%. If you add 45 in and you add all these other types in, you get up to about 90%. That's all types. And then squamous cancer is 16 and 18, and all these other types is very similar figures, but adenocarcinoma is mainly 16 and 18 with a bigger proportion of 18 and a proportion of HPV 45. So if you protect against all of these types, you'll get up to about 95%. The papilloma viruses are in a family tree, and they are somewhat related to each other, and they are not like a flu virus that changes every month, or not every month, every year, and you get H1N1 and you get H5N5 or H1N5. This stays very much the same, and these branches represent how long it has been since there's been a change in the genetic appearance of the viruses. So it's been thousands of years since there's been a change from HPV 18 and its cousins, HPV 45, 39, 59, 51, 56. And HPV 16 is related to HPV 31, which is probably the second or third most common HPV type causing cervical cancer. But they are distant relatives of each other, and that's why if you vaccinate against this, it probably doesn't give you any protection against these viruses here. There's no cross protection across there. So we draw all these nice pictures of the vaccine, and you can see these, looks like a sphere, of the virus, sorry, and it looks like a sphere, and it's got these little bumps on it, and there's actually 72 of those little bumps. The companies and the scientists, and Ian Fraser in Australia and a few other people, developed a method of actually making the virus capsid, and that's just the proteins that are on the surface, and we call those the L1 proteins. There's L2 proteins that are lower down, and then normally there would be DNA inside this. But they can make the surface capsid protein, the L1 protein, and they make it inside an insect vector for Cervarix, which is the GSK product, and then these L1 proteins assemble themselves into a sphere, and that looks identical to the natural virus on the outside. So that when the body is immunized against that and generates antibodies against these surface proteins here, it doesn't know the difference between the vaccine and the natural HPV type. And so when you're exposed to the HPV type again, it kills it very well and very efficiently. And it seems to do that, neutralize it. It does that much more efficiently than a lot of other vaccines. With Cervarix, they have the antigen, which is the L1 HPV 16 protein and the L1 HPV 18. And they add an adjuvant to it, and they call their adjuvant system number 4. And it also has some aluminum salt on it. And that enhances the immune response. They decided just to focus on cancer. So these two vaccines, Cervarix and the next one, Gardasil, were developed around about the same time, and they went through studies very close together. Gardasil has similar look to it underneath the microscope. They still make these nice neat circles with the L1 proteins that stimulate the immune response, but they added 4 proteins into it, 4 HPV types, sorry. They added L1, HPV 6, HPV 11 to protect against warts, which isn't going to cause cancer, but it's going to cause warts, and the 16 and 18, and that is manufactured in yeast. Although it's manufactured in yeast, you don't have to worry about patients that have yeast allergies or yeast infections. You're not going to give them any problems with that. And that has an adjuvant, which is aluminum hydroxide. The WHO agreed that we did not have to do studies and wait for cancer as an endpoint. You couldn't vaccinate women of any age and follow them until they developed cancer, because we're going to treat the precancerous changes there. So what they agreed was that we could use CIN2 and CIN3. So all of these studies that were done used CIN2 as 2+ as an endpoint. You could argue that they should have looked at CIN3 as the true endpoint, but they did CIN2+ as the endpoint. And There is difficult to differentiate between CIN2 and CIN3, and that's one of the reasons for doing that. And the new terminology clumps together CIN2 and CIN3. I'm going to give you this data and the results very simply here. This is the quadrivalent vaccine, and in that study they had, if you add it all up, you can look at all complicated things, but they essentially had about 16,000 women altogether, and they followed them for 36 months when I looked at this, and they've been followed a little bit longer now, and they saw efficacy against HPV 16. They saw efficacy of 100% against HPV 18, and some HPV 16 and 18, there was one case or two cases where they went down to 98% for the quadrivalent vaccine. But these are incredibly effective vaccines against cancer precursors on the cervix, whether it be CIN2 to 3 or VIN, and the vaginal things were also protected. They also saw very good protection against external genital warts. They did have some cross protection, meaning that if you were vaccinated against 16, you got some protection against HPV 31 as well. If you protected against HPV 18, you got some protection against HPV 45. The bivalent vaccine had equally good reports, and you can look at this lots of different ways. They're about 97, 98%. In one or two of their cases, they actually defined how they were going to analyze the data beforehand, and there was a patient that had HPV 16 on a pap test and a biopsy at the end, but she'd also had HPV. It was probably not caused by HPV 16, it's probably another HPV type, but they had to call it under that. So they got a very good response rate as well, just as effective, and I'll show you some other data for that in a minute. They saw better cross protection, and they saw more wider cross protection, possibly due to the adjuvant, but they obviously didn't see an effect on warts, and they didn't actually look at warts at all. These were very well tolerated by the young women that received the vaccines. There was very little side effects noted, and the efficacy, and neither of them showed any benefit against existing infections in any of the studies that have been done. If you look at Cervarix, the bivalent vaccine, what they've shown that if they look at, this is patients who were protection against lesions included in the vaccine, and this is according to protocol. The people that were negative followed, and these are the people that were negative initially, and there was very good protection, and these were patients all together. And then if you look at all of the patients together, they actually saw a very good protection against CIN3 plus with Cervarix, which is, as we said, is probably the better cancer precursor. And this is the graph that shows that with time, the vaccine has one or two little cases thrown around, but there is still, as you follow patients, the control group is going to get more disease, and the two curves are going to separate further with time, because there's going to be no effect on the control group. How long do these vaccines last? Well, they've been out for 9, 10 years now, and they've got a group of women that have been followed with Cervarix, and the maximum length they were being followed was up to 9.4 years, and they still have good antibody levels. Some people have asked me about measuring antibody levels. Well, the two companies have methods of taking blood and looking for antibody levels. They don't use the same method, and there is no test you can get to take blood off people and to see whether they've got antibody levels against HPV. It's not a commercially available test, and it would be very expensive and wouldn't help you a lot if you were to use it. But in these studies, they saw good antibody levels that go out to 9.5 years. And you can see here, this is the same dose, response to antibody levels. These curves are slightly different because the units are different. They're using GMTs, and these are using a slightly different assay to measure the antibody levels. But you can see that the placebos are down here, and the antibody levels are higher here. They're higher for 6, 11, 16, and 18. And in this study, they just looked at the effect of giving a booster shot at 5 years, and they saw a big increase in antibody levels with the booster shot. Can you compare the two? Well, you can't really compare the two vaccines. This is patients that all efficacy, irrespective of HPV type, all comers within the trials. And if you look at CIN3 of Gardasil versus Cervarix, they seem to be a slightly higher response rate, or a lot higher response rate with that. But it's difficult to compare those two. These vaccines are safe. They don't contain any living virus. There have been millions of doses used worldwide. In my Canadian data, there's been 3.5 million of the quadrivalents given in Canada as of last year or so. No real serious side effects associated with the vaccine, and no greater risk of adverse events than placebo. Worldwide, there have been over 7 million doses of the bivalent vaccine given with no real adverse side effects. And the recommendations in Canada are that vaccination for women who've already had HPV-related disease is worthwhile because it's safe and may offer protection against the types that they've not been exposed to, or may offer protection against reinfection with the same types. And we have ongoing surveillance, and there's lots of surveillance going on in the Scandinavian countries to look at the long-term effects of this, using registry data to look at the effects. In this post-licensing safety, there was no evidence of association with congenital abnormalities, miscarriages, autoimmune conditions, thromboembolism or death. The only thing that they saw a little bit more of was fainting. Well, if you're going to line girls up who are 12, 13 or 10 and you're going to sort of give them an injection, some of them are going to faint when you give it to them. And that has been happened. You can get skin infections, which has really been a local reaction around that. What about the older woman? I saw this picture, somebody had it a day or so ago. It's a beautiful picture of an older woman who you would possibly think is at risk of lots of things. Looks like she's going to get skin cancers, and certainly head and neck cancers and lung cancer. So both companies have looked at the usage in older women. So these are women, when we say older women in North America, an old cervix is after age 25. And so these studies were done in 25 to 40-year-old women, and they actually saw, this is looking at incidence of 6, 11, 16, 18 related infections, CIN, and external genital lesions, and they saw, these are the placebo group, and this is the vaccinated group. So these are women that have probably already been affected by HPV, and this is looking at future infections. And they saw a significant reduction in the 25 to 45-year-old age group, and they saw it both in the 24 to 34 and the 35 to 45. That was after 3.5 years of follow-up. If you break it down into persistent infection measured by an HPV test on the cervix, they saw a great benefit there. They didn't see many CIN cases in this group of 4,000 women, which shows you the difficulty and how many people you have to screen to get CIN. You have to do a lot of screening, and that's why when you're setting up a screening program, you have to do a lot of screening to get a colposcopy clinic up and running. But they didn't see a lot of cases here, and there wasn't a lot of cases of CIN2 or 3. So they got the main indication for use to prevent infection, and we do know that it does prevent CIN2 or 3 in women. So if you want to use it, it is safe and they can do it. There was also less wart. There was no warts noted. There was also, one benefit was there was a lot less abnormal pap tests. There was no high-grade pap tests, HSIL pap tests. There was one ASK-H pap test and some low-grade pap tests. So the psychological benefit is quite high for those women. So I do offer it to women who are older, and I also offer it to women that have been treated. Some of the questions, all these vaccines were prescribed as being 3 doses, 0, 1, or 0, 2, and then 6 months. You generally should get the vaccine in within a year's time. But do you need 3 doses? There have been lots of studies. I'm going to just show you one because some of this was done in my province. Looking at using, this is Cervarix, and using a 2-dose schedule rather than a 3-dose schedule. There is a study a bit broader looking at using Gardasil for the same in the school-based vaccination system. And what they used, they looked at a study, they designed the study, and they did actually look at an alternate formulation to see whether they needed to do that. They then looked at the antibody levels, and they saw very good antibody levels whether they used 2 doses or 3 doses for both HPV-16 and HPV-18. So they felt that 2 doses was promised to be useful. You have to spread those 2 doses out to 0 and 6 months ideally. And several of the provinces in Canada are actually just using 2 doses in the school-based program. They're doing 0 and 6 months, and they were saving a 3rd dose for later on, so they're vaccinating the young girls at age 10, 11, and then they were perhaps going to give them a dose when they were 16, but they're probably going to save that money and do other things with the money now that they know it's safe. There is there's one paper that came out in November. They were looking at antibody levels from one of the initial studies that was done in Costa Rica, and they actually got good antibody levels after 1 dose of Cervarix, which is very interesting, but there was no efficacy data and there was no effect on disease. So that's promising that you might need 1 dose. I'm not sure whether you'd get the same response with Gardasil as you would with Cervarix, because Cervarix has the immune booster built in with it. But there are examples of diseases where you do only need 1 dose often to do that. 2 doses seems to be okay, but you wouldn't do them close together. You would give them farther apart. What about if you have disease, like you have warts or you have CIN, is there a benefit to vaccinating women to prevent it coming back again? Or to getting reoccurrences again? So both companies have looked at that, looking at their data in the trials, and what they did was actually they had patients that were found to were vaccinated, then got dysplasia, and then were followed, which is slightly different to vaccinating people after they've been treated, but more or less the same, and there have been some other studies done afterwards to confirm that. What this did, this paper done by Jura that was published in the BMJ in 2012, what they looked at was the incidence of subsequent HPV-related disease. So their reduction for any disease was about 40%. CIN or worse was 48%. So you saw a halving of the rates of new problems. So if you've been treated, you get vaccinated, it would say that you're going to lessen your risk of getting recurrent disease by about 50%. Warts was about 63%, and high-grade dysplasia was 73%. So the last chance of being treated again was a lot less. So what that tells me that if you got a safe vaccine that is going to reduce, the patients don't mind getting vaccinated, and they probably have to pay for it in my system, but if they're treated and they want to avoid the chance of coming back to see me again for retreatment, this is one thing that they can do to help them avoid that. So I do offer vaccine to most of my women who do that, who are treated for CIN. Up to about age 40, 45, and after that it's probably not as beneficial. And this is is that the same slide? A slightly different slide. People have gone. The titles are the same, and it's confusing, I think. But essentially the reductions are about the same. One of them would have been vulvar surgery, one would have been cervical surgery. I'm going to leave that be. So we've had vaccines around for quite a few years now. One of the first countries to really vaccinate people broadly was Australia, and they did it in a school-based program. And then they offered free vaccine for all women up to age 25 or 26 to go to their family doctors to get it. And so they've been able to publish very early some results from that. And this is a paper from 2013, I think, but they keep following this data on. The first thing you're going to see, because it doesn't take long to get a HPV 6 and 11 infection after exposure, is you're going to see less warts. So this is Australian women diagnosed as having genital warts at first visit in a sexually diseased clinic, in several clinics across the country, and they started and it was going up in the younger age group. The other age groups were fairly stable. It was going up, and then they started vaccinating. And you can almost see that by 2010, you've gone from about 12% of women having some warts presenting, down to almost nothing. They've actually almost seen they haven't seen any changes in chlamydia or other STIs, but they've seen almost eradication of genital warts in women who are sexually active in that age group. So warts have almost been eradicated in Australia in that group. And you know the psychological trauma of warts causes, so that's significant. The other thing you want to see is if it affects dysplasia. And so they presented this data from 2011. They still were screening very early, so they would pick pap tests very early. And they had very high vaccination rates in those areas, about 79% in the school-based program, 75%, sorry, and good, reasonable 3-dose is in the older age group, the 18 to 28. So this is low grade, this is ascus and LSIL, and you can see the line here is where vaccination started, and you can see there's been no real effect on low grade changes. You might not expect that because a lot of that's going to be caused by nuisance HPV, and is not as much caused by 16 and 18. So there's no real change there in all these different age cohorts. But if you start to look at this for high-grade changes in the younger age group, you can see that they've started to drop off. There's not many here, but the graph shows an improvement. So they're seeing less high-grade referrals, and they're also seeing it in the 18 to, that's just in the very young age group, some of whom were being screened for some reason, and in this age group there was less coming here. So they're seeing a benefit there. So it's working in the real world. There is the prospect of a new vaccine coming down. I'm not sure where it's going to be introduced, but they're probably applying for approval as we speak. Merck developed a non-valent vaccine. This has 6, 11, 16, 18, 31, 33, 45, 52, and 58, so it gets to about 90% of cervical cancers and includes the glandular cancers. And they have presented their data, and a trial of 14,000 women, 16 to 26. Half of them got the non-valent vaccine, half of them got the quadrivalent vaccine, and were followed for 4.5 years. They had very similar immune responses between the two, and they had efficacy for high-grade lesions with the new vaccine that was greater than 96%, and it wasn't inferior to conventional Gardasil for 16 and 18. So that's not been published yet, so you can't see all the scientific data on it. But it's very promising that this is going to replace Gardasil and give you broad protection against up to 90% of cervical cancer and warts as well. So, in conclusion, HPV vaccination is effective. It's also safe. And it prevents, which works well in the young woman and also can work in the older woman. It's preventing recurrence, and the real-world experience is very promising thus far. Thank you very much.